welcome to Grand Rounds today. I'm going to briefly talk about our presenters because I want to leave quite a bit of time for them to be able to go through their presentations. We have a lot of material we're going to cover today. It is CME for ethics as well as substance use, and so there's a lot of things we need to cover. So we're going to have 3 medical students present briefly. Hannah McCool is first. She's a third-year medical student here. She has done quite a bit of research in behavioral health as well, and mostly in obesity, and she is also the treasurer of the Addiction Care Education and Support Group at Texas Tech. Michelle is a 3rd year as well. She is very involved in the leadership of the free clinic here at Texas Tech and has presented at national conferences on the free clinics as well as health disparities. And then Taylor Harder is the president of the Addiction Care Education and Support Club here at Texas Tech. She's an aspiring orthopedic surgeon and has done some research with the Ortho Hand Clinic on neuromodular pain management. And then Chris Townsend has a PhD in counseling. He ended up getting his bachelor's in 1996 with psychology with a concentration in child development, and then his master's in community counseling with an emphasis on addiction. And then his PhD was in counseling as well as counseling education. And so he has been here at Texas Tech since 2017, is part of the Department of Clinical Counseling and Mental Health. He was the 2022 Outstanding Faculty of the Year for that department. He has done a lot of curriculum development and teaching and counseling and in addiction, as well as racial disparities, religion and spirituality, evidence-based practices. So I'm very happy to introduce our speakers. Because the objectives are going to be divided between all the speakers, I'm going to go ahead and share with you the objectives and then pass it on to Hannah to start. So the first objective is to talk about children who have been affected by addiction and also know the impact that has made. Hannah will talk about that. And Michelle is going to talk about signs and symptoms that an individual is suffering from addiction, as well as the motivational interviewing. And Taylor is going to talk about alternative treatments for pain management. And then Dr. Townsend will talk quite a bit about the ASAM criteria for treatment and a lot of options, ethics and options for treatment for patients that we have now. On a personal note, we all got to know each other at the Betty Ford Center. We went as participants of the medical education program, and it's definitely a life-changing experience. And it's one of those experiences that once you've had it, then you kind of want to not just keep it to yourself, but share it with everybody. So that's part of why we're here today, is to share that experience with everybody. So I'm going to turn this over to Hannah to talk about the children with addiction.
Hi, I'm Hannah McCool. I'm a 3rd-year medical student, and I just came back from the Betty Ford Center about 6 weeks ago. So during my week at the Betty Ford Center, one of the many opportunities that was given to me was learning about the children's program and how the staff there helps children who are suffering from families with addiction. So the entire week really hit home for me because my family, like I'm sure many of yours, is all too familiar with the disease of addiction. It was an emotional roller coaster, sharing my own stories and listening to those around me, both different patients and my own colleagues. However, this specific program and then the activity I'm going to share with you today was one of the most notable because my aunt, who's only 7 years older than me, has suffered from addiction for almost as long as I can remember. But before all of that started, she had a baby, my cousin, who until about a year ago only knew a mom who was fighting the battle of addiction and was succumbing to the drug of her choice. So the children's program at Betty Ford Center is a 4-day program designed for children who live in a home with a family member who is suffering from addiction. It doesn't matter if the addiction is from alcohol or drugs. And it's also important to note that while they do promote recovery of the family member, this is not required for enrollment of the child. The program takes 7 to 12-year-old children because they believe this is the age when children are most heavily impacted by the disease. They're finally old enough to realize that their parent is different, maybe unreliable, making choices that are hurting everyone around them. And this is also when the child is old enough to start considering using the substance themselves. The best part about the program is that it's entirely free and they never turn a child away. They are currently having to run 2 programs online and 1 in person each month just to be able to accommodate everyone. And so we've added the link at the bottom of the slide that we can share later if anybody is interested in the program for people they know or patients. A quick rundown of the program. During the first 3 days, the children come by themselves while their families attend other events that are put on by the center. Day 1 focuses on teaching kids that addiction is not their fault. They build an environment that fosters safety and support, and they teach the kids different concepts such as loss of control, addiction, relapse, treatment, recovery, and codependency. Day 2 continues to build off of that and then expands on each kid's experience so that they themselves can discover the impact that the disease has had on both them and their family units. The kids learn to express their emotions and, most importantly, to break this no talk rule that many families that are impacted by addiction have. This is typically the most difficult day for the kids because they are learning how to express themselves. Day 3 teaches self-care, learning to stay safe and mentally well in such an unpredictable and stressful environment. It's on this day that the kids get to write letters to their family members, and they will later end up sharing these while they're still at the center. And then finally, day 4 brings the family unit back together and teaches them how to make plans for the future, how to take care of themselves and each other, and how they can seek a recovery together. So during day 1 of the program, the kids get to participate in an activity called the Bag of Rocks, which was something I got to do myself while I was at Betty Ford. The Bag of Rocks is a backpack filled with 41 pounds of rocks. The kids have no idea what's inside, so they also don't know that each rock has a different emotion word written on them. The kids are all asked to pick up the bag and carry it around the room for a few minutes while they realize how heavy it is. And yes, they said even the little 7-year-olds can manage to pick the backpack up for a while. After everyone's lifted the bag, they gather the kids in a circle, set it in the middle of them, and they start to tell the story. So every person, including you all, carries a bag. Sometimes our bags are full and heavy, and we feel like we're drowning in everyday life, and sometimes our bag feels empty. The difference between most of us and those struggling with addiction is that we know what we have to do to empty it. Sometimes it may be easier than others, and sometimes we can take multiple things out at a time to help lighten our load. For them, something's typically happened where they either don't know how to lighten their load or they just don't see the light at the end of the tunnel to do so. So when it comes around, they end up taking a drink or taking a hit. They notice that the bag feels a little bit lighter, maybe just for 5 minutes, and so they do it again. They do it enough that for a while the bag goes unnoticed, but then they stop, and when they pick the bag back up, it gets even heavier. Maybe they did something bad while they were high, maybe they embarrassed themselves, and all of this has been added onto the load they had before. So they do it again, only this time it takes a little bit more substance for the bag to feel lighter. So they go on a longer binge or use more of their substance, and they feel great because the bag seems to be gone. But then they stop, they want to get better, and the bag is back. And each time it gets heavier. And then eventually, the bag is so heavy that they just can't hold it anymore. And it's not that they don't want to empty the bag. Sometimes it just feels unmanageable, especially when you can't pick it up anymore because it's too heavy. It's at this point that the person who's struggling has a choice. And because we're helping their kids in the program, we hope that they've chosen to get help for themselves. Then the staff tells the kids that each of you has a bag too. And we know it can feel pretty heavy, especially when you're scared for mom or dad or whoever you're here for. But we have to teach you how to deal with the bag now so that you too don't end up in a situation where substances are the only thing that appears to help, especially since we know addiction runs so strongly through families. The bag is still in the middle of the kids at this point, so they open it up and they show the kids what's inside. They pull out rocks that have different emotions on them, such as angry, sad, scared, and more. They then encourage the kids to empty their own bags, and they go around the circle for all the kids to release their sadness, their anger, their fear, all of their secret feelings. One of the main purposes is to normalize these feelings, especially when this age can be such an awkward time to express yourself without adding addiction on top. This activity has stayed with me since we left the center almost 6 weeks ago, because even myself, who's fortunate enough to not struggle with addiction, has difficulties opening up my own bag to discover what I'm feeling and letting that out. As I've practiced this myself and forced those around me to do the exact same thing, I've noticed that I feel much better on a daily basis. At the conclusion of the program, Betty Ford refers many of the families to continuing care programs in their local communities where they can continue to get help and build for their future. The kids are also given the phone number to the Betty Ford Center where they're encouraged to call anytime and to keep in touch as they grow older. We heard about several people who had gone on to medical school or some who had come back to Betty Ford to make a career helping others because it had made such an impact on their own childhood. I also put the link for a story that we heard about. One of the founders of the children's program from Hazelden, Betty Ford, shared his own view on why it's so important to help these children who are struggling with family addictions, along with his own recovery, and it's called The Recovery Book. And so we can also share this link for anybody who would want a copy. As a final note, the aunt that I mentioned at the beginning of my talk is currently 1 year into her recovery. Her and her son are doing super well, and she's working incredibly hard to maintain her own sobriety and build a future for them together. And now I'm going to pass it off to Taylor, and she's going to talk about opioid alternatives and Narcan administration.
All right, good afternoon, everyone. I am Taylor Harder. I'm a third-year medical student. I am going to be talking about opioid alternatives in pediatric patients, as well as going over a Narcan administration for opioid overdose that we had the opportunity to see at the Betty Ford Center. So on this screen, this chart describes current pain management for severe pain in children older than 6 months and up to 50 kilograms. This protocol is used by the Pediatric Advanced Care Team at Boston Children's Hospital. Opioids used include morphine, hydromorphone, fentanyl, methadone, and oxycodone with multiple different routes of administration. So the lowest initial PO dosages include 0.2 to 0.3 mg per kg for the morphine, 0.04 to 0.06 mg per kg for hydromorphone, 0.1 mg per kg for methadone, and then 0.1 to 0.2 mg per kg for oxycodone. Each of these dosages are recommended to be administered at about 3 to 4 hour intervals for each except for IV fentanyl, which is about 30 minutes. So opioids do not come without some disadvantages, including many unwanted side effects, as well as addiction. So side effects include respiratory depression, sedation, hypersomnolence, constipation, urinary retention, nausea and vomiting, excessive itching, myoclonus, as well as delirium and hyperalgesia, which seems almost kind of counterintuitive. It is important to counsel family and friends of our pediatric patients on the signs of addiction. It's also important for us to recognize certain signs as medical providers. These signs include not brushing their hair or teeth, skipping showers, changes in mood, attitude, or personality, sudden mood swings, irritability, spacing out, or angry outbursts, as well as appearing fearful, anxious, paranoid in normal settings with no reason. And so a little bit about what I do and what can we do as an alternative to prescribing opioids that act as an addiction prevention. Currently, I'm working with a team at the Texas Tech Physicians Orthopedic Hand Clinic. We are working to study literature concerning neuromodulators that can replace opioids in the perioperative setting. Two important medications to note include gabapentin and pregabalin, also known as Lyrica. So statistics show that the need for preventative measures include the following. About 21 to 29% of patients misuse opioids that they're prescribed. 8 to 12% of patients actually develop an opioid addiction. Overdose deaths on opioids have continued to rise in the United States, reaching over 68,000, and these were reported in 2020. Also, patients initially prescribed more medication, so say 30 tablets versus 10, used significantly more, had more left over, and were 3 times more likely to still be taking them at their follow-up appointment. So Boston Children's Hospital guidelines also provide alternative medication dosages for pregabalin and Lyrica, gabapentin and pregabalin. These dosages are also provided for children up to 50 kilograms and older than 6 months. So gabapentin is started at 2 milligrams per kilogram 3 times daily, which is about 300 milligrams if you're thinking about a 50 kilogram child. So that started on day 1 and titrated up to 8 milligrams per kilogram throughout the next 12 days. And it's important to note that titration can be done more rapidly for more severe pain. And then children, interestingly, younger than 5 may require 30% higher dosing. And so for pregabalin, it should be used with caution just because it's a controlled medication, but the dosage is 1 milligram per kg per dose up to a 50 milligram maximum nightly. And then over the next 3 days, it can be used the same dosage every 12 hours. And that has some room for increasing over every 2 to 4 days following that, with a maximum dosage of 6 milligrams per kilogram. Okay, so the following articles are from the literature review I've been involved in. The top article in this list includes a cohort of about 45 pediatric patients in a randomized controlled trial for phantom limb pain management after lower limb amputation. And so the dosages used for this were 300 milligrams on day 1 after surgery, and then 600 milligrams on day 2, titrated up to 900 for the remaining days 3 through 30. So in this trial, the outcomes showed that phantom limb pain was lower in the gabapentin group compared to placebo, as well as postoperative pain from the actual procedure. The lower 3 articles are in adult patients that provide support for efficacy of gabapentin for pain management as well. The significance was found comparing postoperative VAS pain scores in gabapentin groups compared to the placebo groups in each of these trials. And so next, I'd like to do a Narcan administration. Dr. Wright actually picked up a little example of one, so I get to show you if you can see. But in the state of Texas, you are able to go to the pharmacy and pick up a Narcan or naloxone prescription without, or medication without a prescription. And so this is good for family and friends that may have children that are susceptible to opioid overdose. And it's also good for medical providers to have in case of medical or opioid overdose in a hospital setting. And so the first step is to notify the correct emergency personnel and lay the person on their back with neck supported and tilting the head back. And then with the Narcan, it just peels open super easily, and then it looks like a little syringe. And so the top part goes into the nostril. Even if the patient isn't breathing, it will still work. And then you hold it like a syringe with your thumb on the middle lever in the middle, and you just push it to administer it as soon as it's in the nostril. After administration, the person should be put in a recovery position, which should be left arm supporting their head, and then in the picture you can see with the left knee supporting the body. And this just keeps the patient from rolling onto their stomach. And so monitoring the patient for 5 minutes is important afterward. If they are not breathing properly or don't wake up, the Narcan can be administered again. And that concludes my presentation, and I am excited to hear from Dr. Chris Townsend next, so I'll pass it off to him. Thank you.
Hello, everyone. I am Dr. Christopher Townsend, glad to be here with you. We are changing order a little bit. Michelle is getting out of surgery. She's on her way, so I'm going to go a bit ahead of her and just kind of share from a counselor clinical perspective some of the things around addictions. I've been doing some of this work for now about 24, I'm on my 24th year as a clinician. And so have worked mostly with adolescents, some adults, but mostly adolescent work. So wanted to share with you all some of the things you should consider, might want to consider as you're doing work with children. And children do become adults. Children with substance use disorders become adults with substance use disorders. So when we look at some of the realities of substance use disorders with our children, sometimes we try to turn our heads and we don't want to believe that these types of things are going on, but you can see the data. I pulled some of the most current data that we have, looking at the National Survey on Drug Use and Health, and you can see 2.1 million youth ages 12 to 17, and we know children start much younger. I've heard reports of middle school children going into school with substances, so we know they're being exposed much, much earlier. But in terms of this particular data, we got 2.1 million youth between 12 and 17 drinking alcohol in the past month at the time of the survey, and 1 million reported binge drinking, which is 3 or more drinks for females, 3 to 5 for our male teenagers within a 2-hour period. And then 3.4 million youth reported illicit substances over the past year at the prior to taking this particular survey. So are they there? Yes, they are here. And when we look at our regional data is pretty significant as well. And we have not had the services available, particularly because we're in a rural community here in Lubbock. But when you look at Texas overall, lots of rural communities, and it's difficult to make sure that we have all the services that are needed to address the substance use disorders. So I'll be talking more in just a moment about what services we do have and what efforts have been made currently. But one of the key things that we all can do as healthcare professionals is to employ universal screening, meaning everyone who walks through your door receives some screening on substance use. And the reason that's important, over the course of my career, I've lived by the data that says 1 in 10 children who need substance use treatment is not receiving it. And part of the issue is identification of those children who are in need, and the tabooness of kind of screening them and assessing them and having a sense of responsibility to get that child to the place that they need to be. But I think we all have to take some responsibility for that. So the sooner we can identify, the sooner we can get that child into services, into treatment, and the sooner we can have better outcomes for this population. And so we want to disrupt the progression. As I start out, children with substance use disorders become adults with substance use disorders. So the clients that we saw at Betty Ford, most of them started using at a very young age to cope and respond to life circumstances, particularly any trauma. And so we want to integrate short screenings into our admission processes. And in doing that, what it does is it gives you a sense of additional questions you may want to ask as you're serving them for the reasons they've come to your services, but to be vigilant and aware that there are some other things that may be going on here, and then make proper referrals for additional evaluations if you see some of these signs, symptoms, and that they've scored positive on any of those screening items. So we want to integrate this into our daily practices. One of the ways that folk have done this, different professions, is using the expert framework or model. This model looks at routine screening that you would employ, providing some basic education around the substance use disorders, and or referring them for some type of prevention type of service to intervene in the use, and receive some treatment services, referral and treatment. And so it gives you those acronyms to kind of move by. It's an actual model that you can be trained in. Lots of information. So when you even Google universal screening, expert comes up. And that's SBIRT is that acronym. It comes up and it's a model that's being used and actually started being used in the medical field initially and has come into the behavioral health field. I've included the reference for a article on that. So if you want to look at it closer, then that will be there as a resource to you all. So it's so critical and important that we have interdisciplinary collaboration. I can't tell you the number of times where I served a child and they had needs beyond my counseling, and I did not have the network to make the proper referrals, which meant that the other things they were dealing with was going to impede my treatment outcomes and progress with this particular client. So it's so critical, and you all know this, that we must have interdisciplinary collaboration. It's best practice for us to be collaborating. And so one of the dangers is that if one person is working on a particular treatment intervention, and then another person comes and prescribes something else, another intervention, then they could actually be in conflict. One of the things, for example, when I have clients who are addicted to a particular substance, they are demonstrating addictive behaviors, perhaps drug-seeking behaviors, and then they're prescribed some addictive, like painkillers or something like that, that's highly addictive, and we are not communicating, so we wouldn't know that that has occurred. And so, but one of the barriers, because of HIPAA, we have to be careful, as you all know, about sharing information, client personal information around their medical records. The Code of Federal Regulations 42 CFR can be a barrier. And I'm opening up a clinic here at the Health Sciences Center, and we're going to be serving substance abuse clients, children and adults. And so because of this federal regulation, I have to protect, there's extra layers of protection for this particular group in terms of what information can be shared, and particularly if there's not a consent. When it comes to children, for example, children can actually come into services and parents not be given consent. The child can refuse to give consent to provide information to their parents, and that creates a huge problem because we're still requiring and asking the parents to pay for the services. I've run into that quite a bit where children weren't ready to share with their parents that they were using what they were using. And as a part of the therapy, I had to work on them being willing to share with their parents what's been happening. For the most part, I've been able to do that. Sometimes they do not want us to speak with their physicians. And that poses a problem for our collaboration, because if I don't have the consent, then I can't speak to you or I can't share. So within our newly built clinic, we have had to have firewalls within our system that would prevent all the other entities, schools, medical folk from being able to even see our records because of this, to add a layer of protection for our clients. But it also creates a barrier for us to do that needed best practice collaboration. So I did include the link for you to look at 42 CFR. If you're not aware of it, if we breach this, it's a $500 penalty, and for each additional, it's about $5,000 penalties for breaching the clients with substance use disorders. And so doesn't mean that we can't work together. We just have to be real strategic and intentional about continuing to work. And it's necessary for parents to be involved and every provider in that child's or family's life to be involved as a part of this treatment process if we're going to get the best outcomes. And so one of the things that I wanted to expose to you, you may or may not be aware of the American Society of Addiction Medicine, but this is a tool that we use in counseling that helps us to make decisions about the level of care and the best placements for our clients. So generally, you hope that you live in a community where you have all the levels of care that are necessary: outpatient, partial hospitalization, residential care. Those types of services allows us to make good clinical decisions about how to best match the client to a service that meets their needs. And so the ASAM dimensions, it's actually a textbook that I'll show you. If you don't mind handing me a textbook, just as a picture. So if you go online and look, there's a link. This is what it looks like. This is what we use often to help us advocate for to insurance companies to get sessions to treat our clients. So in dimension one, we're assessing acute intoxication or withdrawal potential. Dimension two, we're looking at the biomedical conditions and complications that the person may have, because what that means is if one of they're in need for detox services, that's an immediate referral to a residential type setting. Dimension two, if they have medical issues, we might need to get those treated before we enroll them into any type of counseling for their addiction problems. And then we also assess for dimension three, emotional behavior or cognitive conditions and complications. Co-occurring disorders, for example. Dimension four, readiness to change. That's that motivational interviewing that we'll also talk more about today. Are they prepared for treatment? Are they really motivated externally or internally to engage in treatment? Dimension five, relapse, continued use, or continued problem potential. We're looking at what are the risks in their social systems that can contribute to the perpetuation of their use or the exacerbation of their use. And then dimension six, recovering living environment. We're assessing the realities of their environment. Are they living in a drug infested community? Is there substance use going on in their home? So we're assessing all these pieces, low, moderate, or severe, to determine what levels of treatment. Dimension one, two, and three is the medical things that we pay very close attention to in terms of making sure that the person is stable enough to engage in an outpatient service. And if those areas are not stable and they're on that moderate severe level, then we're looking at the higher levels of care, partial hospitalization or residential type services. So just wanted to give you an idea of some of the decisions when you're making your referral, some things that you might have to consider, or someone may ask you about these particular areas. This is why they have this ASAM framework of decision making. And so then I just wanted to share this with you. This is for adults and adolescents, adults on the top, adolescents on the bottom. This is just a demonstration of the levels of care that we hope that we have in our communities, but there's probably very few, if any, communities in this nation that has all the levels of care. And so level one is like your outpatient, where a person goes in 1 to 2 times, probably in a week. If a client is coming to counseling more than twice in a week, they're probably needing a higher level of care, like an intensive outpatient or partial hospitalization level of care. And so intensive outpatient services, we don't have a lot of those for teenagers. That's one of the things I am looking at. For teenagers, it would be 6 hours of services a week. For adults, you're talking about 9 hours of services a week for an IOP type program. And if more services are needed, the client is failing that level of care or they're continuing to use them, we look for the level threes, which is a residential or hospital inpatient medically monitored or not medically monitored. And that's the differentiation between level 3 and 4 when you see these. And so, well, let me say this, go back. Level 3s are like your substance abuse comprehensive outpatient treatments. It's like a day treatment. Then you get into the level 4s where you may have some that are medically managed, and then those that are not medically managed, meaning there's a doctor. If it's medically managed, there's nurses, doctors there 24/7. So just want to give you that kind of overview of that kind of decision framework that we use when we're making referrals. And if you're making referrals somewhere, this is information that we may ask you all to be able to provide us. You may or may not have it, but you may still be asked for that information on a referral document. So I did do a little research. As you all know, with COVID, there's been an increase, a huge increase in mental health issues with the pandemic. We had the pandemic, then we had almost a pandemic with mental health and substance abuse, and we saw substance abuse increase a whole lot in the aftermath, during and in the aftermath of substance use. I think you can now get alcohol to go. I think those businesses popped up during COVID because people needed it, and it was more convenient to give them access. But what that means is that our children gain a greater access also when there's more readily available alcohol and substances. But we have received in our system millions of dollars to serve our community for our mental health needs and our patients. And what we know is that historically there's not been enough services, and it becomes complicated by us having rural communities all across Texas in terms of having access to services. And so what we have is what we're calling Chi Chat, and and I'm becoming just as familiar with this as I am trying to share this with you. I called yesterday psychiatrist and said, I need information for folks that I'm going to be talking to tomorrow to try to explain this complex and comprehensive care that we have. But essentially what we have done with Cater and T-Chat is we've gone into the school systems, and we've gone from it taking children months to get into care to 3 days getting into care. So we've shortened that window of access to services. And we're looking at the school system. So if the client or child can be served in a brief therapy, identified and have brief therapy, then they don't go further into the system. If they need more help, then there are programs that are being developed, addiction, mental health, suicide programs that are out there on an outpatient basis to serve our children and get them into service quickly. And I've given you all my clinic, and I'll share more about my clinic in just a moment. I am a part of that. And so if the brief therapy is not working, then that child can then be referred to a network of providers within our system to provide additional services to them. Underneath that, you see the Child Psychiatry Access Network, the CPAN. That is for providers to call into. And if you need to consult, if you have a child that presents to your practice and it's complicated and you just don't know which way to go, that's what this number and this email address is for. It's for you to call in and get a consult on those cases that will help expedite that child getting into the right services that they need. And so again, it's a whole network, and I don't have all that information yet. Programs are being developed as we speak. And I know we have a backlog of clients even now where we're trying to get up and running. And so that leads to me talking some about my new clinic here at the Health Sciences Center, the Your Life Behavioral Health and Wellness Clinic. This is an effort to, this particular clinic will serve children and adults. We're serving West Texas. We will do telehealth and face-to-face services. And so in order to make a referral, we're asking the PCPs to generate that referral. And so we will either have the client bring the document to their PCP, or if the PCP calls, we can, it'll be on our website. That website has been created as I speak right now. That document will be on our website. You can pull that down and then make the referral. We will be doing screening and assessments here. We're using Vital Sign 6. If any of y'all are not aware of that, that's something that's been used here at Texas Tech Health Sciences Center, measurement-based treatment. We'll be measuring symptoms every time our clients come into the clinic with anxiety, depression, or substance use disorders. So they will get that measurement. We're also using the GAIN assessment, Global Appraisal of Individual Needs, which is also an evidence-based assessment. We're using these evidence-based methods because we are going to be doing research. We want to be able to inform our practice in terms of who's coming and what the needs are, so that we can continue to enhance the services. We'll be providing individual therapy, family therapy, and group therapy. We're capable of what we're good at, that I know right now, based on all the years of experience faculty has, and the clinicians we will be hiring, is we'll be serving mood disorders, substance use disorders, behavior disorders, and any trauma disorders that will come in because of life experiences. I've added our phone number there. As soon as we have the infrastructure, IT is here working now to get all the computers up and those things, and we'll be ready to serve the community. But again, I just want to go back to that slide. These numbers here are points of contact for you, entry doors, when you need to make referrals to get the client to the right place. We have established on Fridays times where we can get together and triage children. And so what we have and what we're going to have is much better than we've had historically. So I'm going to stop here and pass it on to Michelle, and hope to speak to you in just a moment if you have any additional questions.
Hello. Okay. Thank you, Chris. I'm logging on now. Sorry again for the impromptu rearrangement, but it gave me time to catch my breath. Can you guys hear me? So my name is Michelle. I'll be touching more on alcohol use disorder as well as motivational interviewing. So we can start off with what is addiction. So the DSM-5 the DSM-5 gives 11 criteria for addiction under 4 main categories: impaired control, social impairment, risky use, and pharmacological criteria. And substance use disorder is a spectrum, so it can go from mild, moderate to severe, depending on how much of these criteria that you meet. You need only 2 to meet the criteria for diagnosis. So being aware of these things so that you can recognize it not only in family and friends and patients, but as well as colleagues, being aware of kind of the lesser known criteria. So some of the misconceptions about addiction. So I've listed a few here. Some of the ones that I'd kind of like to highlight is having addiction is a moral failing. Alcohol is different from other drugs. People are kind of easier to brush off alcohol addictions because alcohol is legal. Senior citizens don't get addicted or don't have addiction disorders. If you can still do your job, it proves that you aren't addicted. Or I'll lose my job if they learn that I'm being treated for addiction. And what I would like to address with this is, under disability rights laws, you can't be fired for acknowledging an addiction or seeking treatment for it. What you kind of run into trouble with is if your addiction is causing problems and the responsibilities of your job. So the medicine, so 4.5 million individuals were identified as having alcohol use disorders from age 12 and up. And this was a study done in 2019. And as Chris addressed, these numbers kind of have only gone up since COVID. So we can only expect that these numbers have increased. And this is for alcohol specifically. So alcohol withdrawal, this is kind of the presentation as far as what to expect with someone going from alcohol withdrawal. I wanted to touch upon it really quickly because unlike opioid withdrawal, alcohol withdrawal can be fatal. So in recognizing the signs and kind of the time frame of that is important. So initiating the conversation. So this was a study done that showed 94% of PCPs failed to recognize early signs of alcohol abuse, and up to 40% of pediatricians failed to recognize signs of drug abuse. And among the reasons cited for misdiagnosis was lack of adequate training, skepticism about the effectiveness of treatment, and discomfort in discussing substance abuse problems with the patient. So we kind of hope to address some of these things through training and hopefully through practice and getting comfortable with these conversations. So motivational interviewing is kind of where that comes in. So what it is a patient-centered counseling approach that focuses on enabling behavior changes, that aims to explore and resolve ambivalence about changing behavior. So this doesn't necessarily have to apply to addiction or substance use disorders in general. You can have that non-compliant patient who has a hard time controlling their diabetes and use motivational interviewing there. So what motivational interviewing is, it has the communication skills, which is open questions, use open questions, affirmation of positive thoughts, reflections, so the active listening component, and then summaries, which kind of steps beyond the active listening component. And then different techniques to employ when using motivational interviewing. So determine discrepancies, express empathy, avoid arguments, roll with resistance, and support self-efficacy. And as you can see, there are a few quotes or phrases that you can kind of use to kind of coax these different techniques. So with the stages of change, I'll go into it a little more in my next slide, but there are 6 stages of change. This one is a little more adherent to kind of substance use disorders and addiction in general. But again, this can kind of be applied to any area of behavioral change. So if you want to overlay motivational interviewing with these different stages of change, the first stage is pre-contemplation. So the patient has not yet acknowledged that what they're doing is problematic. And I think I saw a question in the chat asking, let's say you have a middle school patient that doesn't see their marijuana use as a problem. Well, that student is in the pre-contemplative stage, and kind of what the goal of the pre-contemplative stage there is, or your plan of action would be trying to raise awareness so that you can get them into the contemplative stage. So what you might do in that case is assess, what their goals are in life, especially with middle school. They don't necessarily have a job that maybe they have at risk losing when you ask them to kind of weigh the pros and cons of their behavior. But I would be asking them, what do you see yourself doing? Like, what are your goals for the future? How do you see your marijuana use as kind of helping you achieve these goals? And how do you see your use keeping you further or hindering you from achieving these goals? And a lot of this is kind of getting the patient to convince themselves rather than them being felt that they're being led to a place that they don't want to be at. So the next stage would be contemplation, where they acknowledge that they have a problem, but they don't really see the need to change. They're not ready for changing. And what you want to do at this stage is try and resolve that ambivalence and help them towards choosing change, in which you get to the determination stage, in which the person is committed to changing and is kind of putting together a plan. So what you want to do is kind of encourage small initial steps and reinforce any positive outcome or any positive step made. And from there, you help identify appropriate change strategies, so help putting together a plan with that. in which you move on to the action stage, in which the individual is now taking steps towards change but hasn't quite stabilized that process yet. So what you want to do is help them implement these change strategies, as well as promote or help them eliminate potential relapses. So this can be planning for relapse. It doesn't necessarily have to be a part of their journey, but you need to prepare for kind of every possibility at that stage, and as well as promote self-efficacy here, in which you move on to the next stage of maintenance, in which the patient is in more stable place of change and has achieved their goals, or is working on continuing to achieve new goals that are being made. So what you want to do in this stage is develop new skills for maintaining recovery. So these are things like following up with support, reinforcing intrinsic rewards, and developing relapse prevention strategies. And then the third stage, which doesn't necessarily have to be a part of someone's journey, which is recurrence. So having your patient understand that relapse and recurrence can be normal. So not to beat themselves up if this is a part of their journey. It's just kind of pushing them so that they can continue to the next part of the cycle. So my biggest takeaway from the Betty Ford experience was the humanity of it all. And I think that's something that all of us can attest to, as well, as kind of seeing the person behind the addiction, and which can be hard when you kind of always see someone in an acute setting. Compassion fatigue is very real, but kind of understanding the humanity and the fact that everyone in one way or another has been touched by addiction, whether it is personally, whether it is through family, but understanding the person behind it, I think, will help go a long way in helping our fellow man. So I'm going to stop screen sharing so that we have time for questions.
There's a question in the chat about marijuana, and I think Michelle covered it pretty well with motivational interviewing. Is if someone's in that pre-contemplation stage, that's pretty well. But I'm going to have Chris is here with me.
Yeah, I just had a couple points about that question. Marijuana is one of those substances where we have so normalized it in our society and in communities where people don't even consider it a drug, but it's more of an herb, and children will debate you and if they're not motivated. And so what I do is I just keep educating. I keep educating, and I say, these are the facts, these are the truths, this is the research, because oftentimes people will argue with you about whether it's true or not. They think it's some conspiracy that we're doing often about marijuana. But I try and tie also to things that they're interested in, things that they're motivated by, and try and teach them how marijuana can impact those things. So if you are trying to do well academically, then marijuana can cause amotivational syndrome, make you lazy. It could create a state-dependent situation that if you were studying while you were smoking, then now you got to be high to take the exam to recall some things. But mostly what I have seen, some groups of people will adhere to that, while others, you just have to start having consequences and teach them about how the consequences have come from their use. Marijuana is a hard one. But those are the things historically that I've done is try and tie it into motivation.
Thank you for listening to our Grand Rounds.